أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم اللهم صل على سيدنا محمد وعلى آل سيدنا محمد وأصحابه وبارك وسلم أما بعد السلام عليكم ورحمة الله تعالى وبركاته. To those who may not be very familiar with that greeting, essentially it is a message, a universal message, whereby we beseech the Almighty, our Creator, to send His peace and blessings upon each and every one of us today. Welcome to this, the second edition of Sunday Forum. The last edition, we received a number of people calling us to tell us how much they enjoyed the program. Thank you very much for that positive feedback. However, we would also appreciate that if you could assist us in making your suggestions so that we can improve the program as we go along. That in itself will be highly, highly appreciated. What do we have on the program today? Well, first and foremost, two very important and compelling topics. The first one is lifestyle scaling down as one heads towards old age, a very important topic, and we will be grappling with that in a few minutes' time. Secondly, we salute today on the program, in the second half of the program, all our frontline warriors, our frontline workers, every doctor, every nurse, every support staff member that has formed a formidable team in our country to fight the pandemic, the COVID-19 pandemic, and we'd like to pay tribute and salute them today. And inshallah, at the end of the program, we end off with a very beautiful and inspiring and an amazing message from two sisters who are both doctors in Malaysia of how they've taken their expertise to the homes of elderly people and trying to assist them and alleviating the plight of COVID-19 for them. Well, first and foremost, old age, change of lifestyle, loneliness, long days and even longer nights, words like discomfort and distress, issues which are very prevalent in many a home today. And to discuss this very real and unfolding situation, I have with me today a very formidable team. First and foremost, Haseena Parker is a social worker, practicing for many, many years, specializing in mental health. Then we have Dr. Imthiaz Hoosen, a specialist psychiatrist. Dr. Imthiaz, thank you so much to you as well, and thank you for coming. Second time you're around here, highly appreciated. Thank you for being here. And last but certainly not least, a friend of mine of many, many years, very well-known personality in the community, Mr. Javed Dalvi, a financial advisor. Javed Saab, Assalamu alaikum and welcome to you.
Wa alaikum salam, shukran for having me.
Members of the panel, if I may, paint a landscape, a sketch, a picture of the community that we knew 25 years ago. At the time, the economic involvement was very different. Basically, people were either in business or some form of trade. 25 years later, alhamdulillah, we cannot thank Almighty Allah enough. We have today in our community a very well-educated group of young people. But it's through the blood, sweat and tears of their parents that they are what they are today. Parents hardly see their children today. Parents are lonely, big homes, in some cases financial distress. And the community is a community that's steeped in emotionalism, and it's a very conservative community by nature. Haseena, would you say that is an apt description of what the community was 25 years ago and what it is today?
It is very important for the age group you're talking about in terms of downsizing or downscaling lifestyles to take cognizance of the processes that we go through. So initially we will need to think, are we able, number one, do we have the ability or inability to be able to live and sustain ourselves? And this can be from your physical health, whether you're physically able to actually look after yourself, and this comprises of everything. You might have the resources sometimes to have domestic employment, but generally it is, can you run your household on your own? Can you maintain yourself? And at what costs? And I'm sure Javed will speak about costs and finances later. And so we need to look at how do we evaluate our lifestyles as we age. And just as we build a future in terms of financial security, in terms of education, profession, etc., we need to almost look at how do we start releasing ourselves from those phases that we were in. And there are certain processes that we can follow, and the one is to evaluate where you're at, evaluate your relationships you have with your children, if you have children, with your spouse if you're still a married couple, and also with your extended family, because that all speaks to the support, etc., when you start aging.
So I take it that the operative word is evaluation.
Evaluation.
Javed Saab, has the present generation prepared for old age?
I would think some of them have started preparing for old age, but the common problem in our industry is people start late with saving for retirement, and they always leave it when they're 40. And basically, for you to build up a substantial base in terms of capital, you need between 35 and 40 years to build up a nest egg. And we're going at the moment through this new coin that is being termed by the big insurer, Old Mutual. It's called the sandwich generation. Is not only looking after their own children, but they also have to look after elderly parents or elderly relatives. So in terms of what they coin is the sandwich generation, the percentage has increased from the time they started at 27%. It's standing now at 42% for 2020. Obviously, with the pandemic year, it's gone even worse. It's reached its highest point. So the sandwich generation is the generation that is squeezed in terms of disposable income, having to look after their own children and having to look after elderly parents or elderly relatives that unfortunately they are responsible for.
Okay. Dr. Imthiaz, the sketch which I just painted now, I obviously referred to the Muslim community, but in practice, do you find that it's across the board in society?
Yeah, no, definitely. I think many of the challenges the Muslim community face is no different to the non-Muslim community, and I think we have to recognize that we live predominantly in a non-Muslim society, so we're going to face the same challenges as Muslims that the non-Muslims also face, and I think there's several sort of nuances here that we need to look at. So you mentioned about earlier that we've come from a generation, or rather predecessors, that worked very hard, and in a way they sacrificed a lot for us to have the gains that we have, and for us to have achieved what we have. So I think in terms of understanding sort of when we're dealing with that generation and saying, okay, they must downscale, they must give up certain possessions, we have to also understand where they're coming from, because for them, many of the possessions, many of the things that they have contain a lot of memories.
Sure.
A lot of, it's almost like your essence is in those objects. Absolutely. Because they remind you of things. So it may not be that maybe they hold a diploma or a trophy, but it might be an article of clothing, it might be an heirloom, maybe a piece of jewelry, maybe some furniture. But they've worked very hard for that piece of jewelry or that furniture, and that contains a lot of meaning for them. So for a third party to come and say, oh, it's too big, you might just give it up, go and sell it. It's interesting, I came across something where it said, and they were looking at people whose houses had burnt down. And people are so distressed, and it's not about the monetary value that they've lost, it's about the possessions, the meaning of the things that they lost in that fire. And, for example, we might look and say, okay, just the building that burnt down. But actually the house contains memories. Yeah. Events have happened in there. So when we start to think about somebody at an older level that now needs to move on, or needs to maybe move from their home into another home, or they have to give up possessions, we have to start to understand that for them giving up, it's like you're giving up a relative. And what's interesting is, when we look at possessions, from a very early age, even as young as children who are 2 years old, they have a concept of a possession that's mine. And then you sort of move into, maybe 5, 6, 7 years old. We're very familiar with kids having, their favorite teddy bear, their blanket. Yeah. So even at that age, we have an emotional attachment to something. Then you go into teenage years, your sense of dress, what you have, portrays your identity. So the thing you have is part of your identity. So who you are and also what you're trying to communicate. And then think about young guys, like, they get their first car, 18, 19, 20. What do they do with their car? They're doing it up, they personalizing it, mags, and spend all their time washing their car. It's an extension of themselves. It might be a possession, but it's an extension of who they are. People sharing gifts, like again, teenagers, they might buy a gift for a friend, but that gift is an extension. It's about their identity that they're sharing with their friend. Think about people in their 20s or 30s now, maybe they acquire their first house. They start to get possessions. Again, all of that is a sense of their identity. What you put in your house reflects your identity. What you dress, think about your dress sense. Your dress sense communicates who you are, right? So for example, you might have a T-shirt on of a particular football team. It's part of your identity, but also you're communicating that identity to others.
Sure.
Think of Muslim community, people wear thawb or kurta or hijab. It's your identity, but also communicating that identity to others. So we are constantly throughout our life doing this. So it's actually no different for the elderly. So think about how you accumulate friends over your lifetime, and the longer you have those friends, the deeper those relationships. So the longer you have a possession, the deeper the relationship with that possession. So that possession is actually a relationship. And just think about how many people, we talked about traveling earlier. You go on a holiday, you bring back a souvenir. The souvenir might not have a lot of monetary value, but it evokes a memory. I mean, think about people go on Hajj, they bring a rakam, they bring something, and every time they look at the rakam or they look at that object, it reminds them of the Hajj or the Umrah. And the value of that memory is so much. So understanding that concept of, these things that people own are more than just material possessions. They contain their identity. It's about relationships. It's about meaning for that individual. And also it might be about achievements. So that object or that thing that they have is what they achieved in life. It might look trivial to us, but for them it's something huge. So to tell somebody just give it up or just give it away is not recognizing the importance that it has for that individual. But there obviously are ways in which we can help them with that.
Haseena, support structures in the community. Do we have adequate? Do we not have enough? Or what can be done to give much more support, especially to the elderly people?
Okay, I just want to pick up from what Dr. Hoosen said in terms of the meaningful relationships or attachments that individuals have. So I think the first thing is to actually start the conversation. We often assume that it's okay for people just to give up their possessions and let go of their belongings. But I think for downscaling purposes, it is a mind shift that needs to happen. And I think it's
is that the important word, mind shift?
In some cases, yes.
Okay.
But it's also understanding, as Dr. Hoosen said, the attachments of your hard work and sweat and your personal possessions you have, whether it's a property or a car, etc.
Yes.
And the importance is to start the conversation early. And we wait too long, like Javed said, sometimes they wait too late to invest in money, but the conversation needs to start way early. And what is age? Age can be relative because your downscaling can also be relative. Anything can happen at an early age, as in your 40s or in your 50s. It need not be in the senior years as we know it. So start the conversation early with your relatives, with your children, with your spouse, to say, look, we've got this, we've worked hard for it. Start to assess, what can we keep, what that is meaningful and full of memories, what can we let go. And also what support, as you were saying, what support you have in order to sustain you. So do you have a child that's living with you and you're living with them in the same house? So you let go of your onus of burden or responsibility and you hand it over to the living adult child. Do you have that support? And again, it comes to the evaluation. Do you live independently all the years, and what other support structures do you have? Financial support, housekeeping, as I said earlier, etc. And then also what community and family support do you have? You mentioned the word in your introduction, loneliness. So we need to start having the conversation earlier to prevent that loneliness, to prevent the distress, to prevent the aloneness, and also look at the property. Are you going to live on your own, and how big that scale of property is? Can you maintain it, and what can you do in terms of reaching that lifestyle?
So early on in my conversation with you, the word was evaluation. I suppose now it's realization. One needs to move towards a stage of realization.
Yeah.
Javed, young people, would you say they are heeding the call to prepare themselves better nowadays compared to, for example, our generation?
Yes, I think nowadays the youngsters are definitely taking up financial products and doing things to obviously build up something for the future. Retirement is got to do not only with putting money in a retirement plan or in a pension fund. It's also got to do with buying property early, and paying your first property, which is normally your house, paying it off as quick as possible, and then you can build on that. If the longer you start and the longer you do things where you're wasting capital, the longer it's going to take for you to build up your retirement capital.
So when you say paying off as quickly as possible, I know some of the Islamic institutions have got the 7-year period that you can pay off as quickly as possible. Would you recommend that?
Excellent. I know of people that has taken up the offer with Islamic institutions to pay off the bond within 7 years. I think it's fantastic. However, there are certain drawbacks which some of the people don't like. But it's an excellent idea. You could use any financial instrument with other banks as well. But you could actually go into the bank and find out what is the amount you need to pay to clear your bond in 7 years.
Okay, I think then the important point is to be try to become debt-free as soon as possible in your life.
Absolutely.
I think that's the important point, to become debt-free as quickly as possible.
Absolutely.
Right? Dr. Imthiaz, a very controversial point, if I may pounce on you with that. I know that the whole concept of old age homes is very taboo in our community, and especially in the mindset. And earlier on, I was speaking to Javed Saab, and he was actually telling me that so many Muslim people are in old age homes at the moment. It's very sad, but that is the reality. But as opposed to a old age home, what would your view be to a concept of a retirement complex where people are still very near to their families, near to their loved ones? They've sold a big house, scaled down into a retirement complex. Instead of 5 bedrooms, you have maybe 1.5 bedrooms, just a simple bathroom and a single garage, and near to your family, near to facilities. And in our case, very importantly, for people of our age and older, very near to a place of worship. What would your view be on that?
Yeah, look, I think my view would be I'd be very supportive of it. And again, looking at the non-Muslim community, particularly the sort of more middle class, sort of white community in South Africa, they certainly have taken up a lot of this, and you'll find many of these complexes being built and being sold for quite a lot of money. So I think one of the things we have to recognize is that, particularly in our community, lifespan is increasing. So although when you look at the whole of South Africa, relative to maybe first world countries, we've got a lower lifespan. But when you look at the more affluent middle class, our lifespan is similar to that of a first world country. So we do have a 2-tier system in our country. We have to recognize that generally people are going to come from our community are going to easily live into their 70s, 80s, which also brings on new challenges, because that wasn't the case with previous generations.
Yes.
And that brings a whole bunch of complexities. So it brings complexities in terms of, you have another 20, 30 years post traditional retirement, maybe your 60s, that you're going to live. So for many people, that brings another lease of life in the sense that they can now engage in other activities, having maybe stopped work, they've got some funds, but now they've got the energy and the time to engage in new activities. So it's not necessarily a negative, it can be a positive. Secondly, there's also the health factor. So generally most people are going to be relatively healthy, but we also know with age, the risk of increase or the risk of illnesses increases. And usually when you look at the spend, the medical spend, it's greatest in the last few years of life. that's the greatest amount that you're going to spend compared to the rest of your life. So many of these retirement complexes are built with that in mind. So the idea is that you might have, as you said, maybe a flat or a little house that might be 1 or 2 bedroom for the able-bodied, so you have your freedom, you can come and go. The other important aspect, and particularly given in our country, is the security aspect. So they're living in a complex that's secure, it's got security facilities, so there's a degree of safety that they have. Another advantage is that, as you mentioned, about time. So many of their family members may not necessarily have the time to engage with them. So being in a complex like that, they're actually able to engage with other like-minded people, similar age. So you find many of these people actually have more social stimulation in a complex than they probably would do sitting at home.
Yeah, yeah.
So it's not necessarily a negative, depending on how it's set up. And many of these homes, people are taking up new hobbies, new activities. They bring in people to give talks. So there's a lot of mental and physical stimulation that happens in these complexes. So if it's managed in the correct manner, it can actually be a hugely positive thing. The other thing that also happens is that there's a tiered approach. So you would have, as I said, for able-bodied people, but as people become more frail, they might have step up in terms of care. So they will have perhaps a nurse on the premises or warden on the premises. So for those that might need a little extra care, perhaps they need their medication supervised, somebody to check on them, they've got that facility available. And then for the very frail, perhaps somebody that might need more nursing care, maybe somebody to nurse them 24 hours a day, that is available on the premises. So the advantage with this is that your care might step up, but you haven't left the premises, or rather you haven't left the complex. You might just migrate from maybe one building to another building, but over the period that you might be in that complex, you would have made friends, you would have social contacts, and you can maintain those.
It'll be a far better environment for them.
Far better environment. So I definitely think mentally and physically, and I think again we have to sort of change the mindset. It's not about you dumping an elderly person.
Yeah.
It's actually maybe looking at it that it facilitates their need for stimulation. It provides them a safe and secure environment. And at the same time, you can go and visit them whenever you like, because it's their premises, it's their house.
I want to ask Haseena, in terms of the point that Doctor has made about changing the mindset. In your engagement with people that you deal with, do you find that to be a problem, or do you find that increasingly people are becoming more and more amenable to that change of mindset?
It's both. I can't say no and I can't say yes. In our line of work, you get individuals that start, as I said earlier, start the conversation earlier. There's a preparedness, to retirement or to scaling down, because there's a realization and an insight to that children are educated now, as you mentioned earlier. They're in careers, they marry spouses who are equally in a profession, so both of them, and the socioeconomic, the reasons now for both spouses to work is what it is. So, the realization needs to happen earlier for those who are in that situation. So yes, for some persons who are aging, there is an acceptance that this would be the route to go. And as Imthiaz earlier said, that for some people the attachment, the emotional attachment to their hard work possessions or their properties is difficult to let go of.
Would you say that people are gradually letting go of the emotional attachment, or are they still holding on to it?
It varies individually.
Yeah.
You have to work with an individual, and the processes to follow there would be to look at what is meaningful to you. How do you declutter? In other words, how do you downscale? To look at, you need to document what's of value to you and what is of less value to you. Then you have the conversation with your families. Would you like that to stay in the family so that it's not disposed of or discarded, or would you like to donate it? But mentally and insightfully, you need to be prepared for that in order to make those decisions. And that can only help with conversations in the family or with some professional input to actually psychoeducate, we call it, to understand, the meaning of that. But also to recognize that people do have attachments, and
No,
you
sure.
know, what would the mental impacts be if you take away that? And often, you know, it's also sad in some cases and some individuals in our line of work where others are deciding for you.
That's a very
You know,
important
your
point.
children are deciding for you, your family's deciding for you, you know, but we need to recognize people's independence, their sense of own individuality, what purpose they lived, and we need to actually do it jointly with them.
And
in
would you
preparations.
consider an important aspect being the psychological sensitivity?
Yes, of course.
I'll tell you, you know, in my personal capacity, I'm a collector of LPs.
Yes.
So I've got more than 1,000 LPs at home. My children think, well, what is this? But for me, it means so much. Because I've come from that generation. So it's a psychological attachment that one has.
And that's why the conversation has to happen, because with
Yeah.
technology now, you
Exactly.
can convert the LP, the music on the LP, into a smaller
By
little
the way,
stick.
it's not the same, eh?
But it's not the same. But we need to, but that's, you know,
Yeah,
that's,
no, I
that's the
understand.
discussion you have to have with
Sure,
your family.
What Haseena mentioned, and I think we need to maybe think about this concept locally, where while you alive and able-bodied, it's for you to set out what you would like when you actually become more disabled, either physically or mentally, so that well ahead of time, the family know these are your wishes. And I think that's something that we don't often think about. We sort of think about a will, as in when you die,
Yes.
but we don't think about, well, if I'm going to be disabled or if I have dementia, what would I like? And that's this concept of the living will. And I think maybe we need to think about that.
I like
and
that, the living will.
Yes, so introducing that idea that, you know, in 20 years or 30 years, should the following happen to me, I would like the following to occur. So that's one concept. The other concept, which I should have also mentioned earlier, with aging, and because we collectively are in a population that is getting older and living too much older, longer, the risk of dementia is increasing. And we're seeing a lot of that. And we have to recognize that that's also a new challenge for our community.
Right.
Where many individuals, and again, you know, you talked about the sandwich generation, so that sort of sandwich generation are having to look after not only just elderly relatives, but elderly relatives who have dementia. And this brings on a whole new set of challenges. And one of the things about looking at the concept of maybe a retirement complex or frail care is that sometimes you might have a relative who's living at home with dementia, who's got complex mental health needs, and the family are not able to meet those needs. But they feel guilty because I am going to dump my relative in a nursing home or an old age home. So that's sort of the psychological concept, or the guilt, or, you know, from maybe a religious or cultural point of view, people feel that. But at the same time, they're not able to manage that individual at home for all the reasons you've gave. So you're not actually doing that individual a service either. So maybe we need to really think about, you know, when we have, really elderly people who have lost their cognitive ability or the cognitive function, where are they best going to be managed? And maybe it is best that they be managed by professionals who are able and who's got the skills to manage that. Now, be that in a format of a day center, or be that in a format of, for example, what we talked about, a retirement complex. So I do think that as a community, we also have to change our thinking. It's not just at the individual level that we have to change our thinking, but I think as a community, we have to also change our thinking about, you know, what is happening in our community, what's happening to our elderly, and how do we meet their challenges. And we cannot go back and say, oh, what happened, you know, in my generation or 2 generations ago. It was very different. The challenges were very different. And, you know, you then, if you think about in those days, there was very much a concept of the extended family. But nowadays we know that, you know, even with our community, you know, there's been a breakdown of that extended family, and the challenges that people have is very difficult for them to rely on other family members to pitch in when that support is required. And we're not talking about support that might be short term. We're talking about support that goes over a period of many years. So we have to be realistic about what we as a community are encountering, and we need to look at how can we meet those challenges in the modern format going forward.
There's 2 risks that face all people that retire. The first risk is longevity, which means that your money could run out before you actually pass on. And the second risk is inflation.
Yeah.
If you take a person that retired 10 years ago and you thought 10, 12 grand a month was a lot of money, and if you take inflation into account, his purchasing power has below half over the period.
Very true.
So these are the risks that people don't take into account, and it's the real risk.
Yes.
And it only hits you, like Dr. Sab said, with other people, other family members are unable to support that person that has suffered dementia, for example.
Yes.
All the added medical risk, you know,
Yes.
and the risk and the other cost that also increases all the time, which Dr. Sab alluded to, was the fact that your medical bills increases in the last years of your life, you know.
Yes.
So medical aid is one aspect, and then the shortfalls of the things that doesn't get covered by your medical aid, you know.
I just want to hone in a little bit on the elderly people that feel that it is taboo, it is wrong, it is not correct to scale down. What will people think? You know, this is an important thing. What will people think? I'm going to sell my house. I'm going to get rid of that. I'm going to get rid of that. Are there people out there that can counsel these people, these elderly people who are sitting in this zone of a lot of turmoil that is going through their lives?
Well, I normally advise my clients, especially those that are in retirement, is to keep things simple, to start detaching themselves from the material type of things. Like if they have a big 5-bedroom house, and to perhaps consider selling and scaling down.
Nothing wrong with that?
Nothing wrong with that.
Absolutely.
But at the same time, they have to also realize when you die, there's a big cost. Estate duty and legal fees is the reality.
Yes.
A small estate today can cost you anything up to 50 grand to sort out, you know. And you think about these people don't have additional life cover perhaps. A lot of our old ladies don't have life cover on their life because they never believed in taking out any life cover. So this cost becomes the real cost, and if they don't sell the house while they're alive, and it happens after death, it means that the children now have to feed the bill to sort out the legal
So
costs.
you're compounding the problem.
You're compounding the problem. So the reality is they need to be set down with, like you say, with people like financial advisors or professional people, and actually take a step back and look at their life and see, you know, how can we simplify our life and make it easy for our children to carry on, you know.
Evaluation and realization. Those are the two operative words for me out of this discussion. Haseena Parker, Dr. Imthiaz Hoosen, and Javed Dalvi, thank you very much. Shukran. I really appreciate your time, and I just hope that people are going to heed the call that there needs to be a change in the mindset, and that we're living in different times, and that the days gone by were good days when they were good, but at the moment we need to look at the reality and look forward, and may Almighty Allah ease the burden of each and every one that is finding themselves in a situation of discomfort. Make the life of every elderly person a good one, inshallah, and may they be with us for many, many years to come, and may we all be a great sense of support for them. Shukran, Haseena Parker, Dr. Imthiaz Hoosen, and Javed Dalvi.
Shukran.
And from lifestyle scaling down to the fight against COVID-19, as we enter level 2, we pay tribute to our frontline workers, each and every doctor, each and every specialist, nurse, supporting staff, sanitizing team, security personnel, the admin staff, each and every one we'd like to pay tribute to today. But I thought before we get into the next interview, it will be a good idea to have another background sketch in terms of where we were 5 months ago and where we are now. The predictions then and the situation now. We have with us Dr. Syed Parker, Senior Researcher at the Human Science Research Council, to give us that background sketch. Dr. Syed Parker, Assalamu alaikum and welcome.
Wa alaikum salam, and thank you for having me on your program.
It's a pleasure, Syed. I just wanted to ask you, just maybe 3 main points. Where was the world at the time when the word of the coronavirus, as it was known then, was made known? And when did the world really got to know the full impact of it? Third point is, how did the managing process take place? And finally, how different did we in South Africa manage that process?
Thank you for those questions. I think it's an interesting opportunity for us to look back and to try and understand where we as a species have encountered this. The coronavirus represented a threat to humanity that we have never seen before. What had exacerbated the circumstances around COVID-19, not just from a medical point of view, but from a social point of view, is that the world is increasingly more connected. There are more flights in the air than we've ever seen. People are engaging in business, in social relationships in a far more frequent manner than we've seen before. And due to this, the spread of COVID-19 has been severely impacted. Now, if I take you and the viewers back 8 months, which doesn't seem like a long time ordinarily, but in this instance, the world was a very different place in December. I was myself getting on an aeroplane as a result of where I was going and what I was doing. I was alerted to the threat that was unfolding in Wuhan, in China. But because it is literally on the other end of the world, it wasn't something that was threatening South Africa or my immediate travels.
Something happening far away.
What we call a distal threat, a very far threat. And when I arrived back in South Africa in January, the situation had completely shifted. The World Health Organization stepped in and declared the coronavirus a disease of international concern, and much later on, a pandemic status was given to the coronavirus. The important thing for us to remember is that the world has experienced similar things. Speaking to my own grandmother, I can remember hearing about the Spanish flu of 1918 and 1919. Again, what made the Spanish flu so devastating was that soldiers came back from the front lines during the years in World War I, bringing the virus even to South Africa. We've got many monuments in cemeteries across the country that looks at remembering people and families that were devastated in the 1918-1919 Spanish flu. The lesson that we have learned from that is that the complacency that tends to set in when recoveries occur, as alhamdulillah we are seeing right now in South Africa, is that you find a second wave occurring. And the big threat and the big concern that we have in the human and social sciences is that the second wave, as it was in 1919, was far deadlier.
Is that the Spanish flu?
The Spanish flu. The second wave of the Spanish flu killed more people than the First World War and the Second World War combined.
So we have to be on our guard.
We have to be on our guard. And the key risk, when you're thinking of something like an atypical pneumonia that is spread through droplets, is just protect yourselves, wash your hands, wear your mask in public, make sure you protect the elderly and the most vulnerable within our communities.
And don't congregate if you don't have to.
If you don't have to, don't congregate. So what had happened is the world was on an extreme alert level. The way the virus had moved from China through the rest of the world was unknown to medical science and in human history. And what we had found that in South Africa we had a significant number of weeks, at least 8 weeks, if you want to call it that, advanced warning, where we could prepare our medical staff, where our fantastic medical response really took into account the severe and varied socioeconomic circumstances that in South Africa will affect the numbers in a very different way. What we then saw, the advice to the National Command Council, to the presidency, through the study of epidemiology, which looks at a worst case scenario, a best case scenario, and what would likely happen, is that the numbers projected as a result of comorbidities in South Africa related to HIV, related to tuberculosis, there's diabetes, various social and demographic issues that impacted the health of citizens, made the projections seem a lot worse than what we were than what we originally intended. But alhamdulillah, the medical response, the social response, the compliance from society, from mosques like Gatesville Mosque that took a very early stand on social distancing and on public gathering, has helped us during a state of lockdown to reduce the number of transmissions, the number of infections, and the number of people that have been knocked down, and the number of people that have died as a result of COVID-19.
Would you sum it up by saying that in terms of our management, in conclusion, that we did what is called hoping for the best, but preparing for the worst?
We definitely prepared for the worst, and we got the best. I think we got the best. I think the medical staff, the Human Sciences Research Council initiated a number of surveys at a national level trying to understand South African public response. But what we also did is launch a campaign called the HSRC Heroes, where we looked at not only the doctors, the nurses, we looked at administration staff, security personnel, cleaners that go in and clean the bedding and the floors and the surfaces in the hospitals to try and understand the impact that this has on their lives and their livelihoods. And we forget that these people go to work in the morning, put themselves at risk, look after our sick and our elderly. And we really wanted to pay tribute to them in a way that stands testament to the immense contribution that the medical and the biomedical fraternity across the board, pharmacists, doctors, nurses, and support staff have made to help us as a community and as a society live through an epidemic, which not many people in history can say. We have been warned. Coronavirus has reared its head under MERS and under SARS. Not too long ago, in the early 2000s, we saw this break out in the Middle East. And I think as a collective humanity, what we must learn from this is that as a species, as a organism, we are very fragile. But where we have found strength in our faith and in our humanity, I think we've been able to come together not only to protect each other, but to support each other. And that has been the greatest lesson.
To discuss further and pay tribute to all the healthcare workers in our community as well as in our country. And I'm talking about doctors, specialists, support staff, cleaners, sanitizing teams, security personnel, each and every one of them. We really want to pay tribute to them today. But to do that, we have managed to secure 3 people who have really gone beyond the call of duty. And I'd like to introduce them to you now. First and foremost, Dr. Ismail Abdullah, pulmonologist. Thank you very much for coming into the studio.
Thanks.
A great honor and a pleasure to have you here.
Assalamu alaikum. Thanks for having us here.
It's a pleasure. Dr. Nabeel Bapoo, nephrologist. Likewise, thank you very much. Pleasure to have you here today.
Salam, thanks. It's really a pleasure to be here.
Thank you. And Dr. Hoosen Khalfei, again pulmonologist. He's been here before. Hoosen, thank you very much. Nice to have you here.
Shukran, Uncle Sadal. Thanks for having me, and it's an honor to be on the same panel with Ismail and Nabeel and yourself. Shukran.
Thank you very much. In layman's language, I just want to clear something for the ordinary people like myself. A pulmonologist is a doctor who became a specialist who specializes in everything to do with the lungs.
That's right.
Would that be a correct, simple explanation?
Absolutely.
Okay. And a nephrologist, similarly, doctor who became a specialist, but specializes in everything to do with kidneys.
Correct.
Would that be correct?
That is correct. Yeah.
Okay, right. So we've got that out of the way now. So COVID-19, millions of people around the world infected. 800,000 people have died. In our country, 600,000 people are infected, the latest figures. Close to 13,000 people have died. Yet they are denialists. This isn't really a thing. It's something that's made up. What would your comment be on that?
I think those are the people who actually haven't been affected themselves. They don't have any family members, friends, colleagues that haven't been affected by this virus. We can just look at the worldwide figures. I think the figure is 42 million worldwide being affected by this coronavirus. And the figure is still growing. We also know so many people are asymptomatic. So that 42 million are just people that have been tested. So what about that 35–40% people that are actually asymptomatic and aren't tested? So that figure of 42 million is probably much higher. Yes. So I think, and like I said, it's mainly those people that actually haven't really been affected in any way, a family member that's passed on or it's become sick. Let them become sick and see the fear in their eyes that we see when we come across patients. The viewpoint
is going to change completely.
Exactly.
So it's a real thing.
Absolutely.
It's a real thing. Dr. Nabeel Bapoo, as a medical practitioner, was this your worst nightmare?
Yeah, it's, I must say, I'm not sure whether I can call it a nightmare. It's something I never ever thought about before. It certainly was challenging, and it still is challenging. It's ongoing as we speak, though to a lesser extent. What I can do is sort of maybe describe what's been going on. I mean, in about probably early February, we were sort of looking at things in New York and Italy, and we were seeing crazy scenes of what's going on in the hospitals. And I think myself and maybe my colleagues here, we probably thought, you know, we're preparing for this, but this is not going to happen to us. Towards the end of March, I think we saw our first ICU case then, and slowly things just escalated to round about June, July, when we were really in the thick of things. And I think at that point at our hospital, we must have had around about 70 COVID patients every day, 3 wards, 2 ICUs full of patients.
70 every day.
70 in the hospital for a period of probably at least a month, I would say, you know, and it was quite challenging then. I mean, I think back to a particular time when maybe this was kind of a nightmare scenario for us, where Hoosen will remember clearly, we had, I think, a period of 24 hours where we intubated 6 patients. I mean, it was something that we haven't really seen before. I mean, we intubated 2 patients the one night. The next morning, during our ward round, we intubated another 3. I mean, it was just crazy. And I mean, I remember standing in the ICU and looking from like one end to the other, and every single patient here has the same disease. People are dying all over the world from this disease. We actually had no idea what was going to happen to these patients. I mean, it was really scary.
And it came onto your doorstep.
Exactly.
Came onto your doorstep.
Yeah.
Dr. Hoosen Khalfe, we've of course gone through the whole 5-month cycle now, from the pre to the period of the worst case scenario, and now we're at level 2. Your advice to our viewers looking forward henceforth, with particular emphasis on the big concern about the possibility of a second wave.
Sure. So I think that's a very good point. I think we need to probably bear in mind that the fact that we are now in a level 2 lockdown regulation is more driven by the fact that the economy is suffering, rather than the fact that the pandemic is not an issue anymore.
So it's livelihood at the cost of lives.
Absolutely, absolutely. Yes, we probably have passed the peak. It does seem like that, and we say that with all fingers crossed. But it doesn't mean that we now need to become complacent.
Okay.
And just because we've now been allocated 50 people per gathering and maybe 10 people at your home, those are arbitrary numbers. They're not really backed by strong evidence. So we don't really know that 50 holds less risk than 25 or 100, etc. So we still need to just practice common sense when it comes to the whole issue of physical distancing, wearing masks, sanitizing, and I think those factors still prevail. That's still the order of the day, is that yes, level 2 lockdown is in place and we all have COVID fatigue. I mean, we really are tired of distancing ourselves. We don't see our parents anymore. We don't see friends. And if you're a social being, this is really hard.
Yeah.
So it's very easy now with level 2 to become complacent and think, well, definitely things are better. The hospitals have more capacity. So now we can start having our braais and get together. And that will worry us because we've seen second surges, we've seen second waves in countries like Australia, South Korea, New Zealand. We've seen poor governance in places like the United States where they haven't introduced universal masking, and look at their death rates. We've seen how Brazil has struggled because of poor governance. So from an individual point of view, I think we now need to be more vigilant because we're going to be more exposed. Yes, there'll be more capacity in the hospitals, but the impact on family lives has been so devastating that I think we need to be more vigilant and practice common sense.
So you are saying that one needs to be careful and be very, very wary about a second wave.
Absolutely. I think we need to live our lives. It's important as best as we can, but practice common sense because we are not out of this by any means.
Not out of the woods yet.
And we've, if I'm sorry to belabor the point.
No problem.
But in our experience, we seem to also see that the disease seems to cluster in families.
Absolutely.
And of course, when we have, Ismail will confirm this, when we have gatherings, of course, it's family gatherings. And we've seen that disproportionately, some family members are affected. So you'll find that 2, 3, 4 members in a family are affected. And the outcomes can be quite bad. And we don't yet know why this is, and there may well be some kind of genetic predisposition.
Dr. Ismail Abdullah, many a morning when you are on your way to hospital, I'm driving in the opposite direction, going home from the post office, and normally there would be a wave, but now I've noticed there has not been a wave, and the man is like, is deep in thought.
Everybody looks the same behind a mask.
Deep in thought, okay? The question to you, Dr. Ismail Abdullah, is how do you prepare yourself mentally in the morning when you get up, knowing that you are going to be seeing critically ill people with the possibility of them dying? It must not be an easy situation getting up with that frame of mind.
I think all three of us here, or in fact most of the doctors in South Africa, are all in the same situation regarding this. And I think what drives us probably is seeing when you get these sick patients, and some of them won't make it, and you already probably know when they come in how sick they are, that the chances of them making it is slim, but there are a small percentage that do make it, and the joy that you see on their faces when you give them back to their family and when they reunited with their family, I think that's what drives us. And I'm sure I'm speaking for both Hoosen and to Dr. Bapoo here. And also, what's also happened to us, I think, in most of the hospitals is we formed groups, basically. We're working together as teams, and the team spirit that we've seen in hospitals is unreal. You know, so there has been some positive outflows from what's happened from this pandemic, and the friends that you've made and the colleagues that you normally just used to walk past in the corridor, suddenly they've become much more closer friends. So there's been this team spirit that's built up, which often in private hospitals wasn't there before.
Okay, everybody was just too busy doing
their own thing, you know.
So now you had a common thing that you...
And that type of, where you could lean onto your colleagues, that was very important. And then also coming home, I think, where your family, the support that you had at home from your family, I've got to mention that as well. It's very, very important, I think.
Absolutely. That actually takes me to the next question for Dr. Nabeel Bapoo. If you could elaborate on the point that Dr. Ismail Abdullah has made about the importance of teamwork, networking, and I'm sure the nurses have played a tremendous role as well. So maybe a bit of, a few points on that.
So it was interesting. I mean, this whole experience has sort of made me more proud to be a doctor at our hospital, Vincent Pallotti. Simply because of the way things worked, and Hoosen will probably feel the same way. So just to describe our setup is that we've got two excellent infectious diseases specialists at the hospital who led the response from January already, when we were all sort of slightly doubting whether or not we'll be in the situation. And we basically set up teams, like Ismail said. So we had ward teams, which were sort of comprised of specialist physicians, also aided by GPs. So we had a lot of GPs that came in from outside who sort of committed their time to looking after COVID positive patients in the hospital. So that took sort of the pressure off the physicians. A lot of the physicians there were physicians who were not actually doing acute medicine. So they sort of, came into the fold. Us in the ICU, we had a 4-man team, which is different to how any of us worked before, and it basically took us back to our training days where we had teams of doctors, and we went through the day doing ward rounds. And these ward rounds, like you mentioned, included nurses, included ourselves, 4 specialists, included other specialists who were assisting us on other days, anesthetists, even surgeons. We had physios, we had dietitians, all part of the decision-making process for the good of these patients. I mean, the hospital even came on board and brought in turning teams. So you may have heard that the patients with COVID require proning, so lying on their abdomen as opposed to lying on their back, and that had some improved outcomes. So they brought in specific turning teams to assist with those things, and through that, I mean, we'd like to say we had better outcomes for our patients, the ones that survived, and so on. And then coming back to the point of working in a team, I mean, we had moments of anguish. We were anxious. I mean, we had lots of patients who died, and so it was actually a blessing having a team of people who you could sort of depend on, or who you could sort of just talk to about these things. I mean, it really, it's been very different to the way we normally operate, and I think it was, in that respect, a very positive experience.
Hoosen Khaufi, we're still in the pandemic, a special note of caution to the elderly people.
Sure.
You know, elderly people normally are more prone towards having an emotional attachment to doing what they would normally do, whether it's coming to the masjid or going out or going to see the grandchildren. They do it out of absolute love. But should there still be a need to caution them?
It's such a difficult point, isn't it? And I think, and I can take it from the experience of my dad, you know, so he doesn't see us much anymore. And I'm sure he would love to, and tomorrow is his birthday.
Oh.
But you know, the most important thing is that at this stage, more so now, our elderly need to practice hypervigilance. They need to be aware that with the lockdown regulations relaxing, they are now more at risk. And as much as they want to engage with their grandparents and with their grandkids and with their kids, the best they can do at this stage is probably just practice a little bit of more sabr and just a little bit of more patience and tolerance, because when we do get over this, all of us, I speak probably for all of us, we want our parents to still be there for a lot longer. And if we can just practice a little bit of more patience during this time, at least we'll have them for many years to come.
Inshallah.
And there will be time for get-togethers and gatherings.
Are you talking, when you say a little bit more, maybe a couple of months or longer than that?
It's a difficult one to answer.
Question.
Yeah.
I know it's a difficult question.
It's a difficult one to answer. I don't see things getting better until perhaps the end of the year, to be honest. And we might be wrong, and it probably will be a bit longer, and the infectious disease specialist can probably answer that question better. But until we have a proper vaccine, and most people have been vaccinated, and we have reduced rates, we will probably always have to practice some degree of physical distancing, wearing of masks, and avoiding, you know, in-depth contact. And that has important implications for what we will now start doing in masjids and janazas, importantly. So I think, you know, again, we need to be aware of those risks. And if we are a little bit older and probably not that well, a bit overweight, hypertensive, diabetic, all the more reason to try and avoid and make sure that one still maintains the distance.
Dr. Ismail Abdullah, would you say that the system of hoping for the worst but preparing for the best in this particular case, in terms of the whole question of managing COVID-19, hoping for the best but preparing for the worst, the other way around. I'm sorry, Dr. Nabeel picked it up quickly. Would you say that worked out well?
Yes, I think so. It has worked out quite well. Where, you know, like you said, the teams, I'm not talking from a medical point of view, where we had the teams and we could learn from what's happened overseas in America and Italy, and we could prepare better than maybe some of the other countries and for what was coming our way. Although we looked in disbelief what was happening there, we were quite surprised when it actually did hit us, and it hit us so hard. But we've got through it.
Yes.
We've been through the peak and we're on to the downslope, and hopefully it will keep on going further down.
Inshallah. Now, the reason I'm asking the question is because the Hospital of Hope closed down yesterday.
Yeah.
Okay. So, and they said that it was not really utilized 100%. And there was also the question of having another one at CTICC 2, for which there was
I think
no
their
need.
numbers were, what they were expecting to come forth didn't actually materialize.
So that was really, that was a blessing.
A blessing,
That was a blessing.
Absolutely.
Okay.
Yeah.
Now with the blessing comes the other question. You're based at the hospital next door, Melomed. Normal visiting hours?
Yeah, it's a sensitive question because, you know, we all want to go visit the sick. I think it's one of the hadith as well. But I think in the hospital there's a conglomeration of viruses, if I can put it that way.
Yes.
And quite sick people. Also, there's people that do not have COVID-19. They are in hospital because of diabetes, hypertension, and you just need one visitor that's asymptomatic passing it on to one patient, and you could have a flourish of cases. We saw what happened in St. Augustine's in Durban, where one patient in the emergency unit ended up giving it to, 120 people, and 15 deaths at the end of it. 15 deaths. And you know, we don't want something like that happening.
Yes.
So I think, again, a little bit of sabr is needed. And, you know, I think with video calls and like that, you can still in a way, keep in touch and visit your, if I can put it that way, your loved ones in hospital.
Ultimately it's for
And you're actually doing them a favor.
favor.
You're doing them a favor, absolutely.
Okay. Dr. Bapoo, now that inter-provincial traveling has been made possible, traveling per se is one point, but particularly traveling in an aeroplane. How safe is that today?
Yeah, it's a difficult question. I mean, I don't think there's a lot of data on it, but there have been a few case reports or case studies, particularly in the early sort of phase of the pandemic, coming out of flights between the USA and Taiwan and between like Tel Aviv and Frankfurt. And this came out in the news recently, I think in the last few days. In the one scenario, there were known symptomatic positive patients on flight, and everyone was tested post-travel. I'm not sure at which point post-travel, and everyone, like 300 and odd people, were negative. So from that point of view, it seems to be safe. I mean, they go on to talk about the filtration systems in planes that filters out 99.99% of particles, and that the air is exchanged every 2 to 3 minutes, and also that the risk is the highest within 2 rows of a positive patient. So it doesn't sound too bad. I think my advice would still be, we are living in South Africa. We have, we're in the top 5 in the world. I don't know if those figures are
top 5 for the wrong reasons, by the way.
Exactly. I don't think we can, apply those numbers to us.
Okay.
And I would say avoid, flight travel. I mean, unless it's really necessary.
Yeah. Thank you very much, Dr. Hoosen Khalfe. Before I get to the question, I just want to express on behalf of a very dear friend of mine, and I'm sure many of us, Alimia Chikte, who was supposed to be on the program also, but as you know better than me, the recovery period and process is quite a long one, so he felt that it's not going to be advisable for him to be on the program, but he really wants to thank you very much, and he did mention to me, and it was quite emotional when he actually mentioned it to me. He's a very close friend of mine, by the way, that for 6 or 7 days he was completely out. And the morning that he got up, the first person that he saw touching his feet was Dr. Hoosen Khalfe. And he says he will never ever forget that for the rest of his life. And he really wants to thank you, the entire team. And he says, please tell Dr. Abdullah also, I know him well, even if he was not part of that team, that he wants to thank each and every member of the medical fraternity. And he actually said, I must not forget to mention this to you today. So having mentioned that, I come to the question which is a little bit more somber, in the sense that how did you manage to share the dreaded news when a family member passed on, and mentioning that news to the member of the family? Couldn't have been easy.
Yeah, it wasn't easy. That's the short answer. It really is. It's difficult, and it never is easy. And I think Nabeel and Ismail will both agree. Especially during this time, it's been so difficult because families have brought their relatives to hospital and they leave them there. And
Exactly.
When we haven't had a successful outcome, that has been the last time they've actually made contact with their relative when they were alive. And
that's one of the saddest parts of this whole situation of COVID-19.
And what compounds things is also the whole mechanism of the janaza process, the vehicle driving past the house, stopping for a few minutes, and then, leaving, which has been so sad to see, and it's been hard on all of us. What has helped is that we've got a palliative care team at our hospital, and I'm sure at most of the hospitals. And they've been invaluable in communicating with the families.
Okay.
So we would call our patients daily and we would update them on what has been happening. And often we would also be able to recognize the danger signs. And when we know that the outcome is going to be poor, we've been able to break that news to them often 5-6 days a week before the time. So we've been able to prepare them for the inevitable time. But we've also had this palliative care team made up of oncologists, psychologists, social workers, occupational therapists, physios, and they've been very helpful. I've seen them play Surah Yasin for some patients, and these are non-Muslim individuals playing Surah Yasin. You know, we've we've had video calls for priests to say recitals to their congregants, and so it's been emotionally hard. It has been. It's a privilege in a way, but it comes with a lot of sadness and a lot of heavy emotions attached.
I'm sure.
And so yeah, it's been tough, to be honest.
Thank you, gentlemen. Before we bring the curtains down, I would like to ask a general question to all three of you, starting with Dr. Ismail Abdullah. Your personal lessons out of COVID-19.
I think it's made all of us a little bit tougher. We've learned a lot about ourselves in this time. You can say you've lived through a pandemic. Not many people. I mean, the last pandemic was the Spanish flu. You know, so I don't think there are many people that are alive that have lived through that, and we've actually lived through a pandemic, and that's made us, I think, stronger people. And whatever is going to come our way in the future, inshallah, we'll be able to handle that.
But that can go on to the CV. Dr. Nabeel, Bapoo, the lessons for you out of COVID-19.
Look, I'd probably echo what Ismail is saying, but I mean, apart from lessons, there was some things that just stood out, you know, and I don't think I'll ever forget, you know. And we talk about this quite a bit, Hoosen and I, is COVID is very different in that patients, when they deteriorate, they're almost still able to have a good conversation with you, which we don't often see in other pneumonias. You know, they're too short of breath to even say anything. So we've been able to tell them, look, you have deteriorated. If we don't put you on a ventilator, you probably will die. So we're going to have to put you on a ventilator. And they always ask the question to us, how long am I going to be on the ventilator? And it's been the hardest thing for all of us in telling them, you know, a few days, or we hope not too long. But, you know, in our hearts and in our minds, we've been thinking, you know, we don't actually know if you're going to get off this ventilator. And this sort of sticks with me. And I think it's something I'll probably never forget, you know. That's one thing. And then the second thing, and probably something that I also would like to mention, is that it's been a real honor working with Hoosen, you know, through this. It's been fantastic. Myself, Dr. Pierre Steed, Dr. Rob Smith, we've learned so much from him. I mean, he's the heart and soul of that ICU. I mean, people have probably said that, but it's the truth. And it's been a real honor, you know.
Thank you. Dr. Hoosen Khalfe, your personal lessons from COVID-19.
I think probably 2 points stand out for me, and the first echoes what Nabeel and Ismail said, is that you know, medicine is a bit of an inexact science. You know, we more often than not, we can predict what's going to happen to our patients. We can make a diagnosis, process of elimination. We can predict which patients will survive. When you're on a ventilator, we know that patient will probably pull through and this patient probably won't. But COVID hasn't read the textbook. It's thrown that completely out of the window. And that's been hard to accept. And in a way, that brings one closer to your Creator. Because, you know, you do everything you can, but ultimately it's up to the Creator. So that's the first thing. I'm sorry, I'm becoming a bit emotional.
Understood. Must have been very, very trying times for all three of you. But like I said before we came live on the program, that I know of lots and lots of people that are admiring all of you. And the tribute is not only to Ismail Abdullah and Nabeel Bapoo and Hoosen Khalfe, but every member of the medical fraternity. Salim Dawood called me the other day, the cardiologist. He says, Sitar, please, it's a wonderful thing, you're paying tribute, but don't forget each and every doctor, each and every member of the fraternity, each and every nurse, each and every person that helped with sanitizing, the security people, the admin people. All of them are superheroes, and you represent the superheroes today. So I really want to thank all of you for coming. I know it's not an easy discussion, because a lot of things that has possibly did take place in the wards, you don't even want to share, because it's so near and so dear to you and so close to you. I know that. But you came here and You spoke so nicely to each and every one, and I'm sure the viewers are really going to appreciate it. Hoosen, is there anything else you wanted to add?
No, I think that's about it. Maybe,
sure?
maybe the second point is actually, now that I've composed myself a bit, is that I think in essence that humanity has shown itself, and the essence of humanity has probably been the goodness and the altruism that we've seen. You know, everybody has pulled together, from the cleaners to the nursing staff, with the real heroes, as you pointed out. Our colleagues here, we've worked so well together. Ismail and I have often bounced things off each other. And for me, that has been the standout factor, is that humanity has prevailed, the goodness of the human nature. People who have got up and have been afraid to fight this, get up every day, they put on their clothes, and they come to work.
Yeah, we're saying, just remember one thing from an ordinary man like me: when the tough gets going, when the going gets tough, the tough get going, eh? So you guys are the tough guys. Yeah. You guys are the tough guys. So really, shukran so much. May Almighty Allah bless the three of you and Ameen. Every other member of the fraternity. Ameen. Dr. Ismail Abdullah, Dr. Hoosen Bapoo, Dr. Hoosen Khalfe, shukran so much. Those were the three representatives of the medical fraternity that we had in the studio today, where we could, in our own humble and simple way, pay tribute to the wonderful work that every member of the fraternity has done. Dr. Ismail Abdullah, Dr. Nabeel Bapoo, and Dr. Hoosen Khalfe. It's now my very great honor and privilege to be able to get a perspective from a nursing point of view in terms of the medical fraternity that has done such wonderful work in the fight against COVID-19. We have in the studio here with us Sister Fadila Harun, who is responsible at the hospital next door, Melomed, for the development of the COVID-19 protocols at the hospital. Sister Fadila, welcome and assalamu alaikum.
Wa alaikum salam. Shukran for having me.
Very nice to have you. We had the doctors on here earlier on, and it was a very interesting engagement that you had with them in terms of the 3 to 4 month period that they went through. What was it like to have to go through this as a nurse? Maybe from the beginning when you developed the protocols and so on.
Okay. So right at the beginning, there was a lot of uncertainty. We were not sure what we were actually dealing with. This was a new virus. So right at the beginning, we needed to prepare for admissions. We needed to prepare our hospitals to make sure that our patients were safe, and most importantly, that our staff was safe. With that preparation, we required a lot of policy development, a lot of training so that the staff understood that the way we work now has changed. The PPE, how to wear the PPE, how to take off the PPE.
PPE is?
Protective personal equipment. So that's
I know that, but yeah. For the benefit of the ordinary viewer.
No problem. So I think the preparation phase, so your wards needed to be, we needed to rearrange the way the hospital functioned essentially. We needed to rearrange the way we worked in the hospital. And that was the first challenge that we needed to do. And we didn't have much time to do that. We literally had to do that overnight. And our staff was able to actually adapt very quickly to the situation. Then obviously the challenge of lockdown, transport challenges, we work 12-hour shifts, so getting to work on time, being screened in the morning, we weren't used to that. Then not going straight to the wards, but now needing to put on your personal protective equipment. So that took time to actually adjust, but again, our staff adapted quite quickly. And then the most important thing that was I think for all of us in nursing was our patient care. Actually being able to touch your patient, actually being able to spend time with your patient, because there was no time.
There was no time, and they had nobody from their own family to be there.
Yes.
So you actually had to perform a double role.
Yes. We quickly realized that we were actually the family. We've always known that when our patients enter the hospital that we form part of their family. But I think during COVID, it's such a lonely disease that we would make an extra effort in the mornings to try and spend time with the patients. And especially the patients, once the phone call comes from the family, or allowing them to actually phone their families, and knowing that we are the only people that they're going to see for the day. But we miss that one-on-one interaction with our patient, touching your old lady and reassuring her that she's okay, because you've got on gloves. you've got on this visor, you've got on this full suit. So there's a bit of a disconnect between you and your patient. And as a nurse, I think that is something we grappled with initially. But the smile, they would see us smiling, they could see the smile in our eyes, you know, that extra, just being extra caring, and knowing that they didn't have anybody inside the hospital. I think that was a big responsibility for us as nurses. And then the joy of seeing them getting better. I think, you know, in general, when your patient does get better and actually walk out of the hospital, you feel a sense of...
knowing that it could have been much worse.
Yes. And also you see your own family in the patients. This could have been your mother, this could have been your father, this could have been your granny. And how would you have wanted them to be treated? So seeing them walking out, I think, was the biggest joy for us. And the lows of losing our patients, you know, it was... You feel like you didn't do enough, you know, you feel like, you know, this COVID was just so overwhelming. And I got to a point where it was a point of just, it's yaqeen now. It's a point of submission, you know. We are in control to a certain extent, but, you know, further than that, it's really not up to us in the clinical setting.
Ultimately, the decree of Allah.
It's ultimately his decree. And I think personally, once I got to that point, I was accepting that, you know, we were doing everything that we could, because right at the beginning, the reality was we were not going to get to everybody. And I think that realization right at the beginning, that the numbers were going to get too much, the beds were too little, there were too little nursing staff to start off with before COVID, and just thinking about how we were actually going to deal with it was quite overwhelming initially. But alhamdulillah, you know, you go through the phases, you sit on your musalla, you speak to your colleagues, and the biggest learning has been the strength of each other, of actually knowing that when I come to work, there's a team, and even when half of the team was not able to come to work, the ones that could come to work, you know, it wasn't a matter of, you know, like, you know, now at work and we've got extra things to do. It was, we need to be here because there's nobody else that can actually look after the patients. So alhamdulillah, we're starting to see a glimmer of hope. We feel we're over the worst of it. And yeah, it's been quite a journey.
I'm sure it was. Sister Fadila Harun, I want to really thank you very much. I also want to take the opportunity through you to thank each and every nurse, not only at your hospital next door, but the rest of the hospital group, as well as all other hospitals. We really salute each and every nurse and make special dua that Almighty Allah must reward each and every one of you and keep on doing the sterling work. And inshallah, may we overcome this nightmare of a period that humanity has gone through over the last 4 or 5 months. But with the dedication that you people show, it gives us much more strength to know that we are going to reach that end. Shukran so much for that.
Shukran so much. Just I want to say that we felt your du'as. We really did.
Alhamdulillah. Shukran for that. Before we bring you that amazing clip of those wonderful doctors from Lenasia, 2 sisters by the name of Dr. Fatima and Dr. Safia Lambat, allow me very quickly to express my appreciation to the production team, Brother Siraj Parker, Samir Parker, Brother Anwar Umar Rumane, Brother JJ Abdurrahman, as well as a very special thank you to all the participants on today's program. And also a note of appreciation to Rosie's for the beautiful decor behind me, as well as Nisa Gaibi for the absolutely superb artwork. Until we meet again, enjoy this amazing, inspiring and wonderful clip of the 2 sisters, the 2 doctors from Lenasia doing absolutely superb work, going beyond the call of duty. Until we meet again, Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh.
As the virus tears through the cities of South Africa, the residents of one community are trying to rescue themselves. Welcome to Lenasia, on the outskirts of Johannesburg, where inhabitants have given up on the government. Self-preservation has been taken in-house as thousands of people fall ill. Akila Nosaka is a single mother who recently tested positive for COVID-19.
When I be giving you a little bit of oxygen right before we take you to hospital.
Her chest is aching and her mind is racing, but she doesn't want to stay in an overcrowded hospital.
Do you think you will have to go to hospital?
No, because I've got my kids at home and I mean, they need me and I need to get better.
Yeah, but let's change the filters. The filters need to be changed for COVID patients.
That's the head of the community ambulance service, Abu Bakr Saeed, and he's done something remarkable from his office at the local mosque. He's built a parallel healthcare system to treat people like Akila at home.
I must be honest with you, the government hasn't been doing much at all. We can't be sitting back and waiting for the government to do something because it will never happen. So that's why we needed to be out there making a difference.
Together with partner organizations, Mr. Saeed is hurriedly securing advanced oxygen machines, which turn ordinary bedrooms into critical care beds.
We have over 60 units available for the community.
You've essentially created 60 hospital rooms.
Absolutely, that's what it is.
Critical care rooms in this community.
Yeah. So by having 60 of these is exactly what we did. We can provide for 60 people at a time and try and make a difference to 60 lives. It's not just the one life. Sorry.
It is an extraordinary concept, but home-based intensive care requires specialist doctors to oversee it, and sisters Fatima and Sophia Lambert are part of the team. We found them donning biohazard gear on the grassy verge of Nightingale Street.
We as South African doctors are very, very used to improvising. This is what we need to do, and we improvise.
We followed them into the home of resident Mohammed Saluji, who has been fighting for his life for the past 4 weeks. His oxygen levels were worryingly low, and he'd been coughing up blood in the early hours.
On speaking, a cough is being induced, so he's unable to hold a long conversation without him having these cough spasms. Yeah.
Dr. Fatima prescribes steroids and pain relief, but the burden of care falls primarily on his loved ones, who serve as the fill-in physician and the 24-hour nurse. And it isn't easy. We could see them struggling with the oxygen concentrator.
Yeah, we couldn't figure out that. We're the champions, right? We're going to win. Just be positive.
After 30 minutes or so, Mr. Saluji climbed onto his bed, his body aching with exhaustion.
You've had a tough time, haven't you?
God is testing us.
You've got a good team here.
Excellent.
Yeah.
Dr. Lambert and Dr. Lambert had one more house call to make, donning their PPE in the patient's driveway. Inside, we found Hawa Bibi Garwood resting in the master bedroom.
How are you feeling? I'm feeling
She suffers from chronic conditions like diabetes and high blood pressure. But to the doctor's surprise, she seemed to be recovering from COVID-19.
It's 94. Breathe in and out, right? The first time we saw her, her oxygen levels were sitting in the 60s, 63.
Okay.
And now we're seeing it at 93.
Okay.
So it's a huge, huge improvement.
The doctors and their machines are important, but Mrs. Garwood says her daughter, Sophia, has kept her alive.
But she looks after me very nicely.
Yeah, okay.
She's, and she even sleeps with me at night. She's also studying, so she's working till late night, and then she comes and sleeps with me.
Oh.
Yeah.
Okay, so your daughter is actually sleeping here with you as well?
Yeah, she sleeps here with me.
Okay. Right, she wouldn't be able to do that in hospital?
No, she won't be able to do that in hospital.
Now we can breathe.
The stress and fatigue are written on Fatima Lambert's face, but she says she's determined to keep going.
My family is actually complaining because I'm in ICU. I'm also in anesthetist, so I'm in anesthetist and intensivist, a mother, a wife, but it's the time when we can give to the community. So we put everything aside and help this, inshallah. Yeah. And then you see, their smiles are our smiles. Yeah. Virtual hug. Okay. Yeah, thank you.
لا يستوي أصحاب النار وأصحاب الجنة هم الفائزون لو أنزلنا هذا القرآن على جبل لرأيته خاشعا متصدعا من خشية الله وتلك الأمثال نضربها للناس لعلهم يتفكرون